Today we will see what is VAP. VAP means ventilator associated pneumonia. Some book it described as ventilator acquired pneumonia. Due to ventilation, patient acquired pneumonia. To say ventilator associated pneumonia or acquired pneumonia, you should ventilate patient first. They define ventilator acquired pneumonia. The patient develop pneumonia after 48 to 72 hours of endotracheal intubation. I will repeat it again. Patient develop pneumonia after 24 to 48 hours. 48 to 72 hours. After 48 to 72 hours of tracheal intubation. So, if your patient develop fever and positive sputum culture and radiographical changes after 48 hours of tracheal intubation, you can think about ventilator acquired pneumonia. There are two major types of ventilator acquired pneumonia. One is called early ventilator acquired pneumonia, other one is later. Later one typically appears after 5 days, but there is another specific things of this categorization. Later one usually associated with more resistive organism because of the antibody. If you have intubate the patient, most of the time that patient is on antibiotic after 24 to 72 hours. Because of that, if that patient develop pneumonia after 5 days, most probably may be resistance organism. I will tell what are the organism, possible organism. Before I am moving into the possible organisms, the ventilator acquired pneumonia has a diagnostic criteria. One, there should be clinical signs. There should be clinical signs. Number two, there should be microbiological evidence. Microbiological evidence. Number three, there should be radiological evidence. We'll see what are the clinical signs. Patient should be pyrexial, fever, high WBC, or large amount of secretions. Patient can have fever, high WBC or large amount of secretions. Microbiological, positive sputum culture. Positive sputum culture. The radiological evidence are progressive chest X-ray deterioration or pulmonary infiltrate. So now you know what is ventilator acquired pneumonia. That ventilator acquired pneumonia is a nosocomial infection. That means hospital acquired infection. It happened after 48 to 72 hours of endotracheal intubation. The hallmark of the ventilator acquired pneumonia is it has a clinical signs of fever, high WBC and secretions with a positive microbiological culture, and the radiological also they shows progressive chest X-ray changes or pulmonary infiltrate. So if your patient having those features, you can diagnose your patient having ventilator acquired pneumonia. We'll see what are the possible organisms of ventilator acquired pneumonia. When the possible pathological organisms again can be divided into less virulent group and more virulent group. More virulent group usually associated with late VAP. Less virulent group usually associated with early VAP. So if you want to have some kind of ventilator associated pneumonia, better to have early VAP. But if you are getting early VAP, that meaning your immune system is too poor. Because of that, the non-resistance organism also can act in your body. So most common organism are Streptococcus pneumoniae, Haemophilus influenza, methicillin sensitive Strep aureus, methicillin sensitive strep aureus, gram negative bacilli, gram negative bacilli, E. coli, Klebsiella, and some enterobacters. But in the later VAP, more resistant organisms like methicillin resistant strep aureus, Pseudomonas aeruginosa, Acinetobacter, and extended beta lactamase inhibitors bacteria. So now you know there are two major type of organisms depending on whether it is early VAP or late VAP. The later methicillin resistant strep aureus, Pseudomonas, Acinetobacter, and EBLI or ESL, extended beta lactamase inhibitory bacteria. I think this group is more common to you because this one we are taking as a more serious one. This one usually can be cured with simple antibiotic. Strep pneumonia, Haemophilus influenza, methicillin sensitive strep aureus, gram negative bacilli, E. coli, Klebsiella, and Enterobacillus. So we will see what is the pathogenesis of ventilator associated pneumonia. The pathogenesis of ventilator associated pneumonia is multifactorial. I will repeat it again. Pathogenesis of ventilator acquired pneumonia is multifactorial. Your patient is already immunocompromised. Usually we are ventilating patients with multi-organ failure with immunocompromised patients. Because of that, whatever the organism come into the lung can multiply there and you can develop pneumonia. In addition to that, during the endotracheal intubation, you can damage sinuses and this area, paranasal sinuses, maxillary sinus, and posterior throat. You can damage. With that, infection can multiply there. Nowadays, they are growing infection most of the time like a coronavirus in ant, TB as usual. The infection can grow there, and in addition to that, because of the ET tube, we usually keep the ET tube here. Because of the ET tube, here due to trauma, because of the ET tube, that ciliary function going to be impaired. Ciliary function, cough reflex. Your ciliary function, cough reflex, all are going to be impaired with the ventilation. Wait a minute. Your ciliary function going to be impaired with ET tube. Because of the trauma, your upper airway can be traumatized, then bacteria can be easily multiplied. In addition to that, if you are going to do a frequent procedure like frequent suctioning or frequent ET tube change, with that bacteria can go into the lower respiratory tract. So there are multiple mechanisms. One is the infected material can enter through the side of the ET tube during the ET tube removing and reinserting. In addition to that, when you are handling the ET tube, when you suctioning the ET tube, the secretions can dislodge, the bacterial biofilm can dislodge into the distal bronchiole. Due to the prolonged ventilation, the inside of the ET tube, bacteria will grow. Because your antibiotic cannot reach the ET tube. It can only reach into the sputum in the lesser amount and blood to the large amount. With that, bacteria can multiply there. During your suctioning port and suctioning procedure, that can dislodge and can go into the distal bronchioles. So, those are the mechanisms of pathophysiology of ventilator acquired pneumonia. I will repeat it again. One thing is your patient is already immunocompromised right now. Your patient is already immunocompromised. In addition to that, their oropharynx area colonized with infective bacteria. Two reasons. One is due to trauma. Second one is because of the immunosuppression. Here there can be resistance organisms, and salivary mechanism also impaired, coughing mechanism also impaired, ciliary action also impaired. Because of that, clearance of the mucociliary clearance will be impaired. In addition to that, inside the ET tube there can be biofilm generation. So with the biofilm generation, when you are going to suctioning, that biofilm can dislodge and can go into the distal bronchioles. So it can infect there. In addition to that, if you are going to change the ET tube frequently, what happens is, once you remove that, little bit of secretion can go through the side of the tube. So because of that, your patient can get ventilator acquired pneumonia. So most of the things we can prevent. We'll see how I am going to prevent those things. Before I am moving into prevention, who are the people group in high risk, who are having high risk of ventilator acquired pneumonia? The patient with advanced age. Again, as I told earlier, we have to divide this. We have to categorize to take maximum mark in the exam, but when coming to the patient, we have to somehow do whatever the mechanism, all the mechanisms, somehow we have to do. We'll see what I am going to do in exam. So, risk factors for development of ventilator acquired pneumonias can be divided into patient factors, and interventional factors. The patient factors are advanced age, low albumin. Patient with low albumin have a high risk of getting ventilator acquired pneumonia. COPD, bronchial asthma patient. COPD and bronchial asthma patient, and impaired consciousness, low GCS. Because of low GCS, microaspiration can occur without knowing the patients. In addition to that, multi-organ failure, large fluid volume resuscitation, and aspiration of upper GI material, We'll see what are the interventional factors which increase the ventilator associated pneumonia. The prolonged ventilation, high level of sedation. If you are going to give a high level of sedation to your patient will can develop ventilator associated pneumonia. Other one is neuromuscular blockers, use of proton pump inhibitors, sometimes H2 receptor blockers also. I will explain those are in the later. NG tube also they found to have a little bit increased the ventilator associated pneumonia. Supine position. If you are going to keep your patient in the supine position for a long time rather than head elevation, your patient in high risk of getting ventilator acquired pneumonia. And the frequent circuit change and transfer outside the ICU. Also, they found to have risk factors of developing ventilator associated pneumonia. I will repeat those again. The risk factors again can be divided into interventional risk factors and patient risk factors in order to take large amount of marks. Patient factors, as you all know, advanced ages associated with poor immunity and poor cough reflex and ciliary function. With that, patient can develop ventilator associated pneumonia. Low albumin, your lung is heavy and boggy with the fluid filtration. Because of that, there are easy media for growing of the bacteria. COPD and bronchial asthma patients have high risk. Low GS patient can have microaspiration, and multi-organ failure and large fluid volume resuscitation and aspiration also carried high risk of getting ventilator acquired pneumonia. How large fluid volume resuscitation carry high risk of ventilator acquired pneumonia? How it happened? Again, the similar picture like low albumin. If you are going to give a large amount of fluid, your intra-lung water amount will increase. The intrathoracic water volume will increase. Because of that, you can develop respiratory tract infection, ventilator associated pneumonia. The interventional factors are prolonged ventilation. If you are not hurried to extubate, that patient can develop ventilator associated pneumonia. If you are going to do high sedations, again can have high risk of getting ventilator associated pneumonia. Neuromuscular blockers also associated with high risk. And proton pump inhibitors and H2 receptor blockers reduces the gastric acidity. In case of aspiration, there are lot of bacterial material can come into your throat and can aspirate. So, if you are going to use H2 receptor or proton pump inhibitors, you have patient little bit of high risk of having ventilator associated pneumonia. And NG tube also reduces the gastroesophageal barrier pressure. Because of that, high risk of aspiration. Superimposition, again the same thing happen, and the prequel circuit change and transferred outside the ICU also associated with moving and those things. Because of that, gastric content can come into your esophagus and can aspirate into the trachea. Okay, we'll see what I am going to do if you have patient found to have ventilator associated pneumonia. Now you know that how to diagnose the ventilator associated pneumonia, what are the risk factors, and what is the pathophysiology of ventilator associated pneumonia. Before I am moving to the ventilator associated pneumonia, what is care bundle? Okay, care bundle is a simple set of interventions. Simple sets of intervention. That means there are multiple interventions, usually 3 to 5. Simple set of 3 to 5 intervention. When implemented together, those should be simple. Simple set of 3 to 5 of intervention, when implemented together, give a better outcome rather than implement individually. I will repeat it again. The care bundle is a simple set of intervention, usually 3 to 5. When implemented together, give a better outcome rather than do it individually. So, to be a care bundle, the intervention should be simple. That means it should be able to practice elsewhere in the country. Another thing is, when implemented together, give better outcome rather than implement it individually. It's like a thread. If you have 4 threads and somebody asks to break it, it may be difficult. But if somebody give one by one at a time, you may be able to break those things easily. Likewise, the care bundle also, when implemented together, it have a better outcome rather than implement together. And in addition to that, 2 more things. One thing is, it should be easily auditable. Okay. Care bundle is simple set of 3 to 5 set of intervention. When implemented together, it gives better outcome rather than it implement individually, and it should be easily auditable and easily able to practice elsewhere in the country. That means it should be simple. So ventilator associated pneumonia prevention care bundle is there. Ventilator associated pneumonia prevention care bundle is there. We'll see what are the component of ventilator associated pneumonia care bundle. Easily we are going to tell it as VAP bundle. VAP bundle. Okay, VAP bundle first one says you have to have general measures in prevention of ventilator associated pneumonia. General measures are hand hygiene. You have to have good hand hygiene practice. Barrier nursing. Minimal handling of the patient. Those are the general criteria for prevention of ventilator associated pneumonia. You have to have barrier nursing, strict hand hygiene and minimal handling of the patients. When coming to the specific thing in ventilator associated pneumonia VAP bundle, it says reduced oral colonization. Reduce oral colonization and aspiration. To reduce the oral colonization, what they recommend is oral care with chlorhexidine. Oral care with chlorhexidine. Chlorhexidine 0.2%, 0.1 to 0.2% chlorhexidine. You have to regularly teeth brush with the chlorhexidine solution and mouthwash with the same solution. You have to do it. And in addition to that, silver coated ET tube. You know, silver is one of the bactericidal substance. If you are going to use silver coated ET tube, the biofilm formation inside the tube will be prevented. So silver coated ET tube also you can use. In addition to that, you can use selective gastric decontamination. Are you ready? Selective gastric decontamination. It means you give us some antibiotic to selectively kill the bacteria. But nowadays they found there are no advantage of giving selective gastric decontamination. Usually you can give polymyxin B or amphotericin B. You can give polymyxin B and amphotericin B to reduces the oral colonization, not the reduce the oral colonization. The gastric material, bacterial load will reduce with those things, but nowadays not recommended. And second one is here the simplest one for the prevention of the VAP is chlorhexidine mouthwash. This is little bit of costly. This is found to have not that much effect. So into the care bundle, what they taken right now is the chlorhexidine mouthwash with 0.2%. Then what they say is the reduced aspiration. Second one, reduced aspiration. For the reduction of the aspiration, you have to prop up the patient 30 to 45 degree. 30 to 45 degree prop up. Even 30 or 40 they did not found to have any beneficial effect, but when you turn more and more like 45, they found to have it can impair the venous return and hemodynamically patient can be unstable. 30 to 45, there is no difference between the 30 to 45 in prevention of VAP, but with the 45 can associated with hemodynamic instability. Other one to reduces the aspiration is which can use to reduce the aspiration is regular measure the calf pressures. Measure calf pressure. It should be somewhere around 20 to 30 centimeter H2O. I will tell what is cuff. In the endotracheal tube, there is a cuff to seal the trachea with the tube. If cuff pressure is gradually reduced, the infective material can jump from upper part of the throat to the trachea, lower part of the trachea, if tracheal pressure low. So not the cuff pressure low. Because of that, you have to regularly measure the cuff pressure. Usually, every 4 hours you have to measure the cuff pressure. Not only measures, you have to document it. In addition to that, third one says reduces the duration of ventilation. Duration of ventilation. For that, they recommended to do a sedation interval. Do daily sedation interval and assess the readiness for extubation. You have to assess the readiness for extubation. Second one is early tracheostomy. They found to have tracheostomy increase the weaning process. Because of it reduces the resistance, easy tracheobronchial clearance. Because of those things, the early tracheostomy will help to reduces the ventilator duration. Then the stress ulcer prophylaxis. Number 4, stress ulcer prophylaxis. Number 4, stress ulcer prophylaxis. This is you can use proton pump inhibitor, H2 receptor blockers, and sucralfate like coating substance. But with the PPI, proton pump inhibitors, what they say is it reduces the gastric acid. Because of that, increase the development of gram-negative bacteria in the gastric fluid. If accidentally aspirate, you have a high chance of getting ventilator-associated pneumonia. So you have to, then what they recommend is better not to use proton pump inhibitor. You can use H2 receptor blockers and sucralfate. Fifth one is deep vein thrombosis prophylaxis. DVT prophylaxis. We'll see how it helps to prevent the ventilator associated pneumonia. If you have DVT, the small microemboli can come into the systemic circulation and can end up in your lung. Your lung can get microinfarction. With that microinfarction, you can develop ventilator associated pneumonia because that bacteria can grow there. In addition to that, in patient with DVT can have prolonged duration of mechanical ventilation and bed rest. Increased bed rest. In addition to that, microinfarct. Because of those two reasons, the patient, we need to have DVT prophylaxis in order to prevent ventilator associated pneumonia. So those are the measures you have to practice in ventilator associated pneumonia prevention care bundle. Ventilator associated pneumonia prevention care bundle. We will see it again rapidly. To reduce the oral colonization, you can use chlorhexidine 0.2, and to reduce the aspiration, you have to prop up 30 to 45 degree and regularly measure the cuff pressure. It should be somewhere around 20 to 30. Have to measure in every 4 hours. And to reduce the duration of ventilation, you have to check daily sedation interval, and you have to plan early tracheostomy in case of prolonged ventilation. And the stress ulcer prophylaxis, what they say is H2 receptor blockers and sucralfate is better than proton pump inhibitors. DVT prophylaxis also important. The chlorhexidine mouthwash to reduce the oral colonization, they found to have very only effective in patients who underwent cardiac surgery. We have to do another research to identification whether it is important in another kind of prolonged ventilated patients. So How are you going to diagnose ventilator associated pneumonia? As I already told, to say ventilator associated pneumonia, you should have clinical criteria and microbiological criteria and radiological criteria. If you have those things, you can say your patient can have ventilator associated pneumonia. But you want to tell it strongly, my patient having ventilator associated pneumonia, somehow I should treat. To say that, there are several scoring systems to identification of the ventilator associated pneumonia. Number one is the clinical pulmonary infection score. Clinical pulmonary infection score. Clinical pulmonary infection score. It says your temperature, leukocyte count, temperature, leukocyte count, tracheal secretion, tracheal secretions, radiological findings, and microbiological criteria. According to those things, we give a marks from 0 to 2, 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 like that. The maximum marks they can get, other one is PF ratio, again 0 to 2. Maximum mark they can get is 12. Out of 12, if your patient having 6, you can strongly suspect ventilator associated pneumonia. I will repeat it again. According to clinical pulmonary infection score, this is the temperature, leukocytosis, tracheal secretions, radiological findings, and microbiological culture, and the PF ratio. They graded according to 0 to those factors. Then if your patient having 6 out of 12, that means your patient can have ventilator associated pneumonia strongly. You have to do something in that case. Number 2. Number 2, Johansson's criteria. Johansson's criteria. In the Johansson's criteria, they says progressive or new radiological evidence. Progressive or new radiological evidence. Your patient should have progressive or new radiological evidence with at least 2 out of 3. There are 3 criteria. You should have at least, with the radiological changes, you should have 2 criteria. Temperature more than 38. Temperature more than 38. Leukocytosis or leukopenia. Leukocytosis more than 12,000 or less than 4,000. Leukocytosis more than 12,000 or less than 4,000. And the presence of tracheal secretions. If your patient having progressive or new radiological evidence of X-ray should show new radiological evidence, and plus fever and leukocytosis, you can strongly suspect your patient having ventilator associated pneumonia. To say ventilator associated pneumonia, you should ventilate at least 48 to 72 hours. Before that, if you are having patient having those features, you are not going to tell my patient having ventilator associated pneumonia. Okay, those called Johansson's criteria. Now you know the clinical pulmonary infection score, Johansson's criteria. 4th one is Center for Disease Control and Prevention criteria. Center for Disease prevention and disease control and prevention criteria. CDC criteria. You no need to know about those things. Just keep in mind there is a thing called clinical pulmonary infection score with the 6 parameters. With the total score of 12, out of 12 you should have at least 6 to 6 ventilator associated pneumonia. And Johansson's criteria with the radiological changes, you should have leukocytosis, you should have fever, or you should have tracheal cistration. Out of 3 you should have 2 with radiological evidence. Or in addition to that, you can use the Center for Disease Control and Prevention criteria as well. Okay, I will repeat all the things in 5 minutes. To say ventilator associated pneumonia, you should ventilate patient at least 48 to 72 hours, and your patient should have clinical features, radiological features and microbiological features. The risk factors you can categorize patient risk factors and interventional risk factors. Pathogenesis, you can see the pronunciation here: immunosuppression, diminished renal function and reduced cough reflexes, and because of the traumatizing of this area, biofilm generations and frequent suctioning. Those are the pathophysiological mechanisms. Then we came into the ventilator associated pneumonia prevention bundle. It says first one is oral decontamination with 0.2% fluohexidine, then head elevation 30 to 45 degree, then not selective, then GI prophylaxis you can use, then the sedation interval you can use, then you can use DVD prophylaxis. 5 set of intervention also there. Then we came into the how to diagnose and how I want to strongly say your patient having ventilator associated pneumonia. For that you have to use the clinical pulmonary infection score or Johansson's criteria or Center for Disease Control and Prevention criteria. Out of 3, I love Johansson's criteria because it is easy to remember, but most of the time clinical pulmonary infection score also they are in practice.